If there was a word or phrase to describe your experience as a neurologist and a headache specialist in the COVID-19 epicenter, what would it be and why?
That's a great question. Probably to be open-minded. I think that the way in which this has impacted both our patients and the way we care for them has been extraordinary and unpredictable. I think that in the beginning, the focus was on the most severely impacted patients, which included, severe respiratory illnesses, operations led by hospital systems to organize critical care staffing and taking care of the sickest of patients. But there is also this massive undercurrent of patients with chronic neurologic disorders that might be impacted by COVID-19 directly, or how we care for them is also impacted because of displaced care, because of lack of in-person visits, immediate adoption of telemedicine, and also how we teach the next generation of neurologists and how to care for patients with COVID-19 or in the disorders that have been pushed to the background during these several months.
Can you talk about specifically the neurology department itself during this time? How has the neurology department adapted throughout the COVID-19, which started a couple months ago?
Any real academic department has three legs. There's the clinical care, there is the teaching, and there's the research. So the clinical care became the focus, of course. And our department, like many others, was faced with having to contribute to a hospital system dealing with a humongous influx of critically ill patients with COVID-19. So on the inpatient setting, many of our trainees, nurses, advanced practice providers, and faculty members had to become COVID doctors and not just neurologists, and sort of embrace the overlying threat of just being a doctor. That the place where we saw that most directly is in our neurological ICU, which basically became a COVID ICU with the rapid transformation, which included sort of lots of terrific educational initiatives to bring up to speed lots of people in our department for how to take care of these patients and not just the neurology of them. On the counter to that is in the outpatient medicine side, is how do we take care of our neurologic patients whose medical illnesses are not going away and who might be impacted by COVID, for example, with headache, which as myself as a headache specialist see that quite commonly. And of course, rapid adoption to telemedicine and trying to use your judgment about who should be seen in person versus who can be seen over tele or video visits was something we had to grapple with immediately. And then on the education side, like all others, just like on this interview, we had to become Zoom savvy. And thankfully, our department prioritized keeping an educational cornerstone, such as morning report, a daily occurrence. In fact, we increased it. We did it for 40 straight days, including weekends. And it became sort of the meeting place for our department every single day, where operational updates from our chair, myself, and other department leaders could be discussed, and also hearing in real time the COVID neurology and the non-COVID neurology to maintain an educational presence for our trainees and others. And then for research, a lot of the research had, of course, bench research associated with our department had to go on pause. But a lot of the clinical research efforts turned towards COVID with a lot of interesting findings and lots of sort of interesting observations that are hard to know if they are necessarily valid in real time because of lack of comparative data, say, to other illnesses. But some of that data has been emerging now.